Venetoclax in CLL for sure has been approved, but we're seeing fantastic data in AML in multiple different combinations. So a lot of people may be aware already of the data of Venetoclax in combination with hypomethylating agents such as azacitidine or decitabine, where the frontline elderly AML population is showing a response rate of about 70%, which is more than 2 times of what we would get with azacitidine alone. And these responses seem to be durable. We're now getting 2-year survivals of 45%, where historically we would get 20-25%. So this is really good, and we're seeing similar data with low-dose cytarabine. Now, one of the good things we have in AML is that there are a number of new agents that are emerging, and we have a lot of preclinical and excellent scientific rationale being developed for new combinations. And so one of the combinations that we have been evaluating in our lab with Dr. Michael Andreeff and Marina Konopleva at MD Anderson has been combinations of Venetoclax with novel therapies based on mechanisms of resistance. And one of the major mechanisms of resistance to Venetoclax is MCL1 upregulation. And there are a few drugs that specifically downregulate MCL1. One of them is a MAP kinase inhibitor, Cobimetinib, and the other one is an MDM2 inhibitor, Idasanutlin. So after doing a lot of preclinical work, which actually has led to some high-impact papers recently published in Cancer Cell, we developed this clinical trial in collaboration with Genentech, Roche, and with multiple centers across the United States and Europe. So the goal of this phase 1 trial was initially to find if it is safe to be combining these 2 agents and what would be the maximum tolerated dose. So this was run as any standard phase 1 novel combination. The study has been ongoing now for about 15 to 16 months, and we have been doing gradual dose escalations. What we've noticed is that the combination in general seems to be tolerated. The most common side effect we did see was diarrhea, but we've started now using prophylactic loperamide for patients, especially for the first 48, 72 hours, and with that intervention we're seeing a significant mitigation in the risk of diarrhea. The other thing is, what we're noticing is that we are getting responses at all dose levels. So we started with lower dose levels of Venetoclax as well as Idasanutlin, and on the other arm, lower dose levels of Venetoclax with the Cobimetinib. And we're seeing responses at all dose levels. The response rate seems to be more in the combination with the Idasanutlin. So on the Venetoclax Idasanutlin, in relapsed AML population, we're getting a response rate of about 35%. And one more point is these are actually elderly relapsed AML patients. So the study inclusion criteria included people who were above 60 years of age with relapsed AML. So this is what I would consider the highest risk group because they're elderly plus relapse, and we did see a lot of adverse cytogenetics and molecular. What was interesting is now at the dose that we have achieved, which is the Idasanutlin either 150 or 200 milligrams in combination with Venetoclax at 400, we're actually seeing very high response rates. Among 12 patients treated in these 2 cohorts in the escalation, we have 6 people who have achieved a CR or morphological leukemia-free state, and these were a median of 2 salvages. So we think that this may be the combination and dose to take forward. So we will be having some discussions and meetings with the larger group of investigators as well as Genentech to decide how to take it forward. But I think the initial signal is quite exciting, especially in an area of unmet need, which is the relapsed elderly AML population. And of course, the next logical step is going to be, well, we have these 2 novel agents. Now, can we add a backbone of hypomethylating agent, low-dose RC, further push what we're seeing with HMA Venetoclax or low-dose RC Venetoclax? So these discussions are ongoing. But I think what is really unique about this study is that in AML, we have done a lot of HMA or chemo or low-dose cytarabine with novel agents. This is one of the first large studies to have a true novel component, which shows that we really are moving forward in 2017 where we can do these kind of studies. The FDA supports it, and the data is becoming quite encouraging.